Today we will be discussing developmental dysplasia of hip in 0 to 6 months of age. DDH represents a spectrum of hip joint abnormalities ranging from dysplasia to subluxation to dislocation. This usually develops in utero or during the neonatal period. Hip dysplasias involve abnormal development of femoral head, acetabulum, or both. The acetabulum may be shallow and femoral head ossification may be delayed or abnormal. Normal development requires the femoral head to remain located within the acetabulum. So, various terminologies used here. First, reduced when femoral head is within the acetabulum. Subluxated, femoral head partially displaced from the acetabulum. Dislocated, femoral head completely outside the acetabulum. Subluxatable, hip can be partially displaced with manipulation. Dislocatable, hip can be completely displaced from the acetabulum. Dislocated hips may be reducible or irreducible. After manipulation, it can come to reduced position or it may not come. History of DDA. In 1832, Diprin first coined the term congenital dislocation of the hip. In 1912, Lee Demany first described the physical click of the joint. In 1930, Putty advocated the early intervention in DDH. In 1937, Ottolani formalized the click or jerk sign of both dislocation and reduction. In 20th century, Lorenz used the reduction maneuver, which was very forceful and caused avian in many patients. That's why he is also known as the father of avian. In 1946, Pavlik replaced brute force with a simple stirrup device, allowing active movements to guide the dislocated hip into the socket. In 1959, he validated Pavlik by reporting the management of 1424 hips with zero cases of AVN. The incidence of DDH dislocation is 1.4 per thousand births. Clinical finding is seen in 2.3 per 100 births. Ultrasound abnormality is seen in 8 per 100 births. Higher incidents are reported when screening involves both clinical examination and USG. DDH is unilateral in 63% of the patient and mostly involve left side. Etiology, it is multifactorial. Factor can be genetic with familial predisposition, collagen defect, maybe hormonal with maternal relaxin or estrogen impact. Mechanical factors, breech, like breech position, oligohydramnios, or swaddling practices can lead to DDH. First, uh, breech position is mostly associated with DDH. It increases risk by 4 to 24 times. First degree familial history increases risk by 12 times. Female sex are more predisposed, that is 2 to 7 times. Oligohydramnios increases risk by 4 times. Firstborn infant increases risk by 2 times. 75 point, more than 75% patients of DDH are female. Estrogen pathway, maternal and fetal estrogen circulate in the bloodstream, which binds to estrogen receptors. DDH patients possess a structurally higher number of these receptors. Hormone saturation induces severe ligamentous laxity. The femoral head becomes unstable within the acetabulum due to this laxity, and which leads to dysplasia. Other the packaging principle gestational constraints, firstborn infants are at twice the risk because of decreased elasticity in the gravid uterus which physically compresses the fetus. This is recently this is recent advancement. Post maturity and high birth weight are also associated with DDH. Because of increased fetal mass, outgrows the available uterine volume, forcing abnormal hip positioning and oligohydramnios, because of insufficient space, insufficient amniotic fluid removes the protective hydraulic cushion, which restricts the fetal movement. Protective factor prematurity is associated with decreased risk of DDH due to low fetal mass and absence of late term gestational crowding. Breech positioning in Breech positioning is present in 7 to 40% of all DDH cases. It increases risk by 4 to 24 folds. While all breech presentation elevate risk due to restricted pelvic space, the frank breech presentation carries the highest specific association with the DDH. This posture applies extreme mechanical leverage directly against the developing acetabulum, physically forcing the femoral head out of the socket. Infants with breech positioning in utero are at risk for residual dysplasia even with a normal physical and ultrasound. Follow-up at the age of 6 to 7 months with radiographs is recommended for the third trimester breech infants to assess for residual dysplasia. Conditions such as metatarsus adductus, congenital muscular torticollis, congenital knee dislocation are associated with are commonly seen with DDH because of sharing of the same pathology, that is restriction intrauterine. Maternal age and delivery type, their relation with the DDH is inconclusive. While CTEV is recent studies found that CTEV is not linked to DDH. Swaddling effect. Traditional swaddling practices, which involve the extension and adduction of the lower limb, create immense tension on the hamstring and iliopsoas, directly levering the femoral head out of the developing acetabulum. Nowadays, safe swaddling practices are encourageable, which involves safe method allow for natural hip and knee flexion, active hip abduction, and entirely free leg motion. So, this video demonstrates how to do a safe swaddling. There was a Japanese study in which showed that the incidence prevalence of DDH came down from more than 1.1% to less than 0.2% by encouraging the safe swaddling practices. Normal development of femur and acetabulum. At 7 weeks of gestation, cleft appears in the primitive limb bud mesenchyme. At 11 weeks of gestation, fully formed cartilaginous acetabulum. At 8 years, majority of the acetabulum shape is locked in. Primary ossification center begins to appear. At 9 years, final epiphysis appears. 17 to 18 years, complete fusion of secondary center. In proximal femur, at 7 weeks, cleft appears. At 11 weeks, fully formed cartilaginous femoral head. 4 to 7 months postnatal, first bony nucleus appears precisely in the center of the femoral head. Late adolescence, physeal closure. Hip development with DDH. So, we see pathological changes in different structures around the hip in DDH patient. In acetabulum shows shallow profile. Oh, acetabulum may be oblique, flattened, thickened medial wall, excessively anteverted. Femur, there can be increased femoral anteversion. Femoral head show maybe aspherical, smaller growth failure. These changes, late changes maybe include subchondral sclerosis and cyst formation in acetabulum and femoral head, as well as osteophyte formation and loss of articular cartilage. Labrum may be hypertrophied, potential displacement and new limbus formation. Ligaments and pulvinar, hypertrophied pulvinar ligamentum teres and contracted transverse acetabular ligament. Capsule may be stretched or enlarged, contracted psoas and adductor tendons. To a point, these changes are reversible, but the exact upper age at which hip reduction will result in a normal acetabular development is uncertain. Barriers to reduction, pulvinar. Pulvinar impedes reduction via volumetric displacement at acetabular depth. Ligamentum teres takes up valuable spatial volume within the acetabulum. Transverse acetabular ligament impedes entry at the inferior acetabular threshold. Inferior capsule presents as an opening smaller in diameter than the femoral head and narrows via Chinese finger trap mechanism. Iliopsoas contributes to narrowing by constricting directly across the capsular isthmus. Natural history. The untreated unstable hip can spontaneously reduce, or if there is pathological progression, it can be dislocated, subluxated, or dysplastic. Barlow showed in his study that he included patients with instability sign positive, and 88% of them resolved at the end of 2 months. In Coleman's study, which included only autolani positive patients, only 21%, the spontaneous resolution rate was only 21%. Yamamuro, in Yamamuro study, in which only autolani positive patients were included, 25% resolution rate was there, and in which only subluxatable hip were taken, 57% reduction rate was there, resolution rate. Clinical features in DDH. In neonate, you can see dislocatable hip, reducible, and classic sign. In infant, hip may be dislocatable, reducible, classic sign, decrease abduction, and Galeazzi sign we can see. Autolani maneuver. This test for reduction. In this, at starting state, hip is dislocated at rest. We give gentle abduction and anterior force to relocate the hip. A palpable clunk as the we feel a palpable clunk as the hip reduces back into the acetabulum. So we can say hip is dislocated but reducible. In Bardot's maneuver, this test for displacement, starting state is hip is reduced at rest. We give a gentle adduction and gentle posterior force. In this, hip if hip fully displaces out of the acetabulum, uh, then hip is dislocatable. And if femoral head displaces but remains within the acetabulum, then it is subluxatable. Galeazzi sign, Galeazzi or Ellis sign identifies real or apparent femoral shortening. It is assessed by observing knee heights with the infant supine, hips flexed, and knee flat on the examination table. In normal hips, there is symmetrical knee height. Positive Galeazzi sign when there is asymmetrical knee height. In a small infant, subtle difference in length may be difficult to identify. A negative Galeazzi sign does not rule out hip dysplasia. Passive range of motion is used to detect instability in hip. Assessing the arc of abduction is a critical marker of joint integrity. In DDH, abduction is decreased while other range of motion may be increased or normal. In newborn infants may have a dislocated hip and still demonstrate normal hip abduction. This is an exception. Classic sign, examiner places the third finger on the greater trochanter and index finger on the ASIS. An imaginary line drawn between the fingers should point towards the umbilicus. When hip is dislocated, greater trochanter is proximal. This causes the line to point approximately halfway between the umbilicus and the pubis. Imaging we use in DDH. First is ultrasonography. Ultrasonography is an excellent tool for evaluating infant hips as it uses sound waves, not radiation. The neonate hip is a difficult structure to imagine with standard radiographic techniques because the hip is composed primarily of cartilage and soft tissue. It gives detailed view of soft and hard tissues about the hip, both in static and mobile modes. So, graph technique, which uses ultrasound for classification of DDA. Classification system is based on angles formed by the sonographic structure of the hip. The baseline, the baseline is the line of the ilium as it intersects the bony cartilaginous portion of the acetabulum. The inclination line is the line along the margins of the cartilaginous acetabulum. The third line is the acetabular roof line along the bony roof. Ultrasonography examination performed at 6 weeks of age or later these examinations are done at 6 weeks or later to allow for hip maturity. This is sonographic picture what we see during sonography. This is ilium line. This is cartilaginous acetabular roof, and this is bony acetabulum. The angle between the cartilaginous line and baseline is beta angle, while the Angle between the bony acetabulum and distal line is alpha angle. So, graph classified hips into 1, 2, and 1, 2, 3, and 4. Type 1 is mature hip, in which alpha angle is more than 60 degree, bony roof is good. But beta one further, it is classified into 1A and 1B. 1A is one in which the beta angle is less than 55 degree, and 1B in which the beta angle is more than 55 degree. Type 2A plus, this is physiological. Hip is immature and appropriate for age. Bony roof is adequate and alpha angle is between 50 to 59 degree. Cartilaginous roof covers most of the femoral head, and it is used in 0 to 12 weeks. Type 2A minus, it is physiological, immature, but maturational deficient. Bony roof is deficient. Alpha angle is 50 to 59 degree. Cartilaginous roof covers the femoral head, and it seen in more than 6 to 12 weeks, between 6 to 12 weeks of age. Type 2B, there is delay of ossification, deficient bony roof, alpha angle 50 to 59 degree, and it covers the femoral head more than 12 weeks of age it is used. Type 2C, 2C is further divided into 2C stable and 2C unstable. Bony roof is severely deficient. Alpha angle is between 53 to 49 degree. Cartilaginous roof still covers the femoral head. Beta angle is less than 77 degree. Type 3A, eccentric hip. Alpha angle is less than 43 degree. Bony roof is poor. Cartilaginous roof is pressed upwards without structural alteration. Proximal perichondrium goes up to the contour of the iliac wall. Type 3B, eccentric hip. Alpha angle more than less than 43 degree. Bony roof is poor, and superior bony roof is roof rim is flattened, and cartilaginous roof is pressed upwards with a structural alteration in the proximal perichondrium goes up to the contour of the iliac wall. Type 4, eccentric hip, alpha angle less than 53 degree, but the cartilaginous roof is pressed downwards. So, class 1 hips are normal, need no follow-up. Class 3 hips are subluxated, needs treatment. Class 4 hips are dislocated, needs treatment. Class 2 hips forms a group in which the degree of abnormality and the need for treatment are less clear. 2C is the most important to identify because it represents a pre-luxation phase that will subsequently dislocate. Graph recommended to treat 2A hips also. 3% of the graph 2A hips fail to normalize without treatment, whereas 17% of the graph 3 hips and 25% of the graph 4 hips fail to normalize. Ultrasonography is very useful for detecting early treatment failures when using the Pavlik harness or other treatment modalities. It is important to note that a normal result with ultrasonography does not completely preclude a later abnormality. Neonates with hips that were stable during the initial examination were re-examined clinically and with ultrasonographically at 6 weeks of age, whereas those with unstable hips are re-examined at 2 weeks of age. If USG study showed no improvement of unstable hips at the second examination, then treatment with Pavlik harness is to begin. At the end of the established waiting periods, 90% of the abnormal hips had become normal without treatment. So there are other classification also other than graph, which uses USG as a modality to classify hips. Herkes and Kumar uses dynamic stress reproduction of Barlow's and Ortolani maneuver during the USG. 4 to 6 mm motion of the head. He terms it unstable hip. Tyson uses the femoral head coverage assessment. More than 50% of the coverage is threshold in this classification. X-rays in newborn with typical DDS, the unstable hip may appear radiologically normal. As the child reaches 3 to 6 months of the age, the dislocation will be evident radiographically. In the infant, the upper femur is not ossified and most of the acetabulum is cartilaginous. In X-rays, we draw a Hilgrenier's line, that is a line through the triradiate cartilage. Perkin line, which is drawn at the lateral margin of the acetabulum, is perpendicular to the Hilgrenier's line. Central line is a curved line that begins at the lesser trochanter, goes up to femoral neck, and connects with the line along with the inner margin of the pubis. Acetabular index, which is an angle formed by the juncture of the Hilgrenier's line and a line drawn along the acetabular surface. In normal newborns, acetabular index averages around 27.5 degrees, and at 6 months, the mean comes down to 23.5 degrees. ISDI classification. ISDI classification for dysplasia of the hip with Hilgrenier's line drawn bilaterally to the top of the trilobate cartilage. Perkins line drawn perpendicular to the Hilgrenier's line at the superior lateral margin of the acetabulum, and the diagonal line drawn at the 45 degrees from the junction of Hilgrenier's line and Perkins line. Placement of the midpoint of the superior margin of the ossified metaphysis, that is H point, can be used to determine the classification grade of the hip, which is classified from 1 to 4. Grade 1 represent a normal hip with a H point at or medial to the Perkins line. Grade 2 is subluxatable hip with the H point lateral to the Perkins line and or medial to the diagonal line. Grade 3 is subluxated or dislocated hip with H point lateral to the diagonal line and or inferior to the Hilgrenier's line. Grade 4 is dislocated hip with the H point superior to the Hilgrenier's line. Other imaging which are used are arthrogram. When done in dislocated position, the acetabular edges are seen and the capsule is enlarged as it extends over the femoral head. The capsule is constricted at the middle portion into hourglass shape sometimes by the iliopsoas tendon. MRI offers Other investigation is MRI. MRI offers excellent anatomic visualization, not commonly used because of expense involved and the need of sedation. Kashiwagi and associates proposed an MRI-based classification of the hip with DDH, in which Group 1 hips had a sharp acetabular rim and all were reducible with a Pavlik harness. Group 2 hips had a rounded acetabular rim and almost all could be reduced with Pavlik harness. Group 3 hips had an inverted acetabular rim and none was reducible with the Pavlik harness. MRI findings include the widening of the findings are iliac bone widening and the lateral drift of the superior and posterior portion of the acetabular floor, the overgrowth of the acetabular cartilage, and convexity of the posterior portion of the acetabular cartilage. Screening programs, the utility of the DDH screening programs is debated. When ultrasonography was used for screening, the treatment rate doubled as compared with using clinical findings alone. In 2006, the US Preventive Service Task Force concluded high rates of spontaneous resolution of hip instability and dysplasia and unclear net benefits from screening. However, late presentation is associated with higher healthcare cost. The American Academy of Pediatrics recommended periodic surveillance and with physical examination and selective hip USG for infants with risk factors such as history of breech presentation, female oligohydramnios that was discussed earlier, and or abnormalities on physical examination. Treatment for neonate, gold standard treatment is Pavlik harness. If on initial examination autolenic test is positive, treatment is started immediately. And or if there is moderate to severe under coverage is less than 40%, or alpha angle is less than 50%, treatment is started immediately. And if there is Barlow's positive hip, treatment can be started immediately or can be waited for 3 weeks. But if there is instability at the end of 3 weeks, treatment should be started. If there is mild immaturity, coverage is between 40 to 50%, and alpha angle is between 50 to 60%, monitoring can be done. This may resolve without a treatment. If ultrasound is not normal by 6 weeks, treatment should be given. 80% of the unstable newborn hips spontaneously stabilize by the end of 2 months of the age, necessitating careful diagnostic stratification to avoid overtreatment. Pavlik harness is gold standard for treatment. Indication are reducible hips in patients not yet able to stand, limited to infant less than 5 to 6 months because older, stronger infants will overpower the soft straps and cannot be effectively treated. Focused clinical teaching is mandatory for appropriate application to the caregivers. Other alternatives for Pavlik harness are Frechka pillow, Craig splint, Ilford splint, Von Rosen splint. In Pavlik harness restricts the hip extension and adduction while it promotes the hip abduction and flexion, which is therapeutic position. Unlike rigid casting, the dynamic nature of the soft straps allow active hip motion while maintaining the joint within the safe therapeutic zone. So, after starting treatment with Pavlik harness, if the hip was unstable at the beginning, then weekly physical examination and static ultrasound while in harness should be done. If hip is stable and reduced, follow-up interval is safely prolonged to every 2 weeks. During the maintenance phase, after achieving a normal ultrasound, all routine imaging should be suspended. At the completion day, we should obtain a stress ultrasound at the time of planned harness removal to definitely confirm stability. How long treatment should be given with Pavlik harness? So there are two algorithms. Algorithm A, in which they say twice the time taken to clinically stabilize the hip plus 6 weeks. And there is one more algorithm which says treat all infants with exactly 3 months in the harness. And people say uh, there should be weaning. Some studies in North American surgeons and somewhere in European surgeons, they wean Pavlik harness after the completion of treatment. The efficacy of Pavlik treatment is 70 to 95%. So, red flags or risk factors for failure are graph 4, those were high dislocation, initially irreducible hips when treatment is initiated after 7 weeks of age, when there is development of femoral nerve palsy during the treatment, static brace treatment, right hip dislocation, and male sex. 12% rate of residual acetabular dysplasia at 6 to 12 months post successful treatment. So, after successful treatment also with Pavlik harness, there are 12% rate of residual acetabular dysplasia. This video shows how to apply the Pavlik harness. Baby should be undressed and correct size should be measured by measuring the chest circumference of the baby at the level of the nipple. These harnesses are also ready-made available. So if there is confusion, one larger size should be used. So first open the straps of harness and place halter over the bed facing in front. Foot stirrup must be placed according to the sides to avoid confusion. The fixed strap of the foot piece is always inside. So it's better to mark which one is right and which one is left so that uh, it doesn't create any confusion for the caregiver. So place the baby supine on the top of the halter. We place the chest strap along the nipple line. So there should be a space of at least 2 fingers beneath the chest strap. You should check shoulder strap with posteriorly. The purpose of the shoulder strap is to keep the chest piece at the level of the nipple line. Strap should be opened of the foot stirrup and secured around the foot. Footpiece anterior velcro should be adjusted to fit foot well. Posterior single strap can be adjusted later. Anterior strap should be put through buckle of the first chest piece to secure and then of the other foot. Straps should be adjusted and secured, keeping the hip in 90 to 110 degrees of flexion. Then posterior straps should be secured to the foot. Strap level of the sticking of the posterior strap should be such to allow for free abduction, which should be gravity assisted, and we should mark the level of these straps so as to reapply later. No, um, no force should be applied for abduction. All position must be rechecked and marking should be done at the end for future reapplication. So, what if a Pavlik harness fails? Then, first line of treatment after Pavlik harness is rigid abduction bracing. This is the final attempt for conservative treatment. And if this fails, then we go to close reduction. And if close reduction fails, then open reduction. With rigid abduction bracing, 82 to 87% of hips uh, that failed with Pavlik harness reduces. If rigid bracing has not reduced the hip, it must be discontinued after 3 to 4 weeks. Prolonged futile bracing is contraindicated. For close reduction, traditionally it was believed that one should wait for ossific nucleus to appear for close reduction. But recently, two meta-analyses found no evidence to support a protective effect against osteonecrosis by delaying reduction. So modern protocol is perform close reduction as soon as the bracing fails, balance prompt reduction with mitigating general anesthetic risk. The procedure is technically easier is in a slightly larger infant. Indication to abandon close reduction are not reducible, not concentric, not stable with close reduction maneuver, requiring extreme position to maintain reduction. If any flag is present, we should abandon close reduction. With hip spica, safe zone, uh, hip spica should be applied in safe zone. Hip flexion in 90 to 100 degrees, abduction in 45 to 60 degrees, and minimal internal rotation. 3 month immobilization protocol. Earlier, mid treatment cast change was done, but now only cast change should be done if the cast is excessively soiled or the child physically outgrows the cast. Outgrowing is rare. Infant typically loses muscle mass and do not grow rapidly while casted. This is the algorithm for treatment. If there is abnormal hip on physical examination or ultrasound, class 1 first group of patients are in which there is immature hip on ultrasonography, but hip is stable. We reassess them at 6 weeks. So if after 6 weeks the hip is stable on examination and USG is normal, then no treatment is required. If there is at the end of 6 weeks there is abnormal ultrasonography or hip subluxates or dislocate, then we should give Pavlik harness. If on initial examination hip was normal or immature in USG, but hip subluxatable or dislocatable, then we should reassess the patient in 3 weeks. Then, if after 3 weeks, if the examination is normal and USG is normal, no treatment is required. If USG is abnormal and hip is subluxatable or dislocatable at any point, Pavlik harness should be given. If Pavlik harness fail, as we discussed, we should start with rigid hip bracing, abduction bracing, and if this fails, close reduction, and if that failed, open reduction. If there is moderate to severe undercoverage in starting only, and hip is dislocatable or subluxatable, from starting we should give Pavlik harness. And if his hip is dislocated but reducible, we should give Pavlik harness. But and if not reducible, we should go for closed or open reduction. So post-treatment, treated DDH hips faces accelerated early joint degeneration. Even with optimal treatment, DDH hips may develop joint degenerative changes at an earlier age than the normal hips. So, 33% of the patient may require further surgical intervention. So, caregivers should be counseled. Rates of subsequent hip surgery remains high. Caregivers should be explicitly counseled regarding the ongoing treatment for radiographic monitoring and testing potential for additional surgical procedures. For standard radiographic surveillance, we should do regular follow-up at 6 months of age, 1 year, 2 year, 5 year, 12 year, and further till skeletal maturity. Radiographic monitoring is recommended until at least walking age with continued surveillance until skeletal maturity being the standard clinical baseline. Thank you.
मोहित कहाँ से बनाया पीपीटी?
Uh, Ma'am, Sajjan and some articles.
Can't be, na, because if there's some articles, then you would have referenced each of them. How is a male child red flag for a public harness and why?
Ma'am, there were some recent study which showed because in male child there is more failures with Pavlik harness.
Why? Which study?
Um, I will share article on that
So
article.
why, if you read them, why?
The reason was not mentioned.
See, ऐसे नहीं करो. We want you all to learn the topic inside out, not just read out. We can read your slides. And relevant क्या है? What should be the order in which you should go about things? Incidents, factors, etiology, clinical this thing. Then if to describe the tests in detail. You spoke about ortholatry and Barlow. I want you to show me in OPD how it's done.
Okay, ma'am.
What are the fallacies of ortolani? In which age it is positive, which age it is not positive? What are the differentials? What about teratologic hip? X-rays and treatment and all कितना पीछे है? Graph and all sonography should be taken as a separate thing, ना? बैठ के सोचो तो सही. Please stop the recording.